Bipolar disorder, management of mood liability. Some key terms that we want to put at the forefront of our mind is mania, which is a person's ability to be abnormally persistent. They have elevated mood, or this is defined as euphoria and elation, expansive mood, which is a lack of restraint in their expressions, irritable mood, because they're easily annoyed and provoked to anger. They can have manic episodes. Manic episodes defined as distinct periods of mania, and mood labilities, that rapid shift in movement from little to no change of external events. So with bipolar disorder, there is the more so the idea that that individual can go anywhere from being very manic, very fast pressure speech, to very slow movement or depression. So with bipolar 1, these individuals are going to have major depressive, manic, or even or mixed episodes in between. With bipolar 2, they're going to have major depression with hypomania. And then you can have your cyclothymic disorders, in which they can go from hypomania and depressive, but not really meet the full definition of what major depressive episodes are like. So when we're looking at bipolar across the lifespan, we're talking about not only children and adolescents, but we're also talking about your older adult. So with children and adolescents, they have depression that usually occurs first, and it's marked by this intense rage. And it's really hard for us to diagnose this, because when you look at child development, sometimes it can be misconstrued as normal behavior. Symptoms are really reflective of developmental levels of that child. So back to, again, our role as nurses, making sure we're paying attention to that so that we don't miss these patients or this part of the population that really needs us to be on cue, and going beyond, oh, this is normal for their child development, to going, let me ask a few more questions to determine whether or not this could actually be signs and symptoms of bipolar disorder. With your older adult, you're going to see a lot of neurologic abnormalities and cognitive disturbances. And with mania, that's going to decrease with their age. As far as epidemiology is concerned, this is prevalent within our own country, within the United States. 1.1% of individuals will have bipolar 1, and 1.4% will have bipolar 2. Symptoms usually begin to present themselves before the age of 25. There is no discrimination between gender. However, there are going to be females who are greater at risk for depression and rapid cycling more than men, and that has something to do with the fact that we also have hormones that often can become unbalanced and just make it hard for recognizing the difference between two, but then also it makes it harder to kind of prevent how often they cycle between mania and depression. With male patients, they are more at risk for having manic episodes. Some comorbidities that go along with bipolar include anxiety disorder, panic disorder, social phobias, and substance use. When we're thinking about etiology, everything that we've discussed, and I keep saying this, but maybe not, there are different aspects that can affect an individual's potential to have bipolar disorder. So we're looking at biologic theories, we're looking at psychological and social theories, and then we're looking at environmental factors. When it comes to treatment and recovery, our goal of treatment is to minimize and prevent either them being in an a manic episode or in a depressive episode. We're going to help not only the patient but also the family learn about the disorder and how to best manage it, because this is a disease process that's going to happen throughout their lifetime. Adding to that will be their priority care issues and making sure that they are safe. With self-assessment, with the manic patient, We got to remember that these individuals are going to be manipulative, demanding, and splitting. And so we have to be united as nurses in a unit. We also have to be aware because it can disrupt not only the unity of the staff members, but it can also disrupt the unity of the milieu. So we have to have frequent staff meetings to be able to deal with patients' behavior and staff response. And then we also have to make sure that we're setting limits consistently. So what one person does, the other person does. When we're doing our assessment, we're thinking about that individual being a danger to themselves or others, because especially either in the manic phase, they are impulsive with their behavior, and in the depressive phase, they're at risk for suicidal harm to themselves or others. So they need our protection. They also need to be hospitalized. They're going to have to be assessed for any medical status that might be exacerbating their disease process. We're going to have to be looking at other coexisting medical conditions and then determining what not only the patient's understanding is of this disorder, but also the family's understanding, that family understanding. So we're going to see from a biological domain changes in their activity, eating, sleep patterns, diet, their weight. We're going to be looking at labs. We always have to start with the thyroid function. If there's any changes in their sexual practice, how are they doing with their medications? Were they previously on antidepressants? Did they discontinue any mood stabilizers? And next, we're going to be looking at nursing diagnosis based on that information that we just went over in the previous slide. So with mania, if they're constantly in a state of increased hyperactivity, then they're not sleeping. So they're going to be sleep deprived. They're not going to be eating, so they're going to have imbalanced nutrition. They're not drinking, so they're not going to have the proper fluid volume that they should have. They're going to have disturbed personal identity, defensive coping. They could be at risk for suicide, violence, and have ineffective coping. On the opposite side of this disorder, the depression, they can have disturbed sleep patterns, imbalanced nutrition, fatigue, nausea, self-care deficit, disturbed thought processes, and sexual dysfunctions. So what do we do for these individuals? We're going to educate them, one, about how to continue to be a part of their activities of daily living and engage in their physical care. We're going to give them medications, mood stabilizers. So often you'll see these individuals on lithium. You're going to see them on Depakote or valproic sodium. We're going to see them on carbamazepine and Lamictal or lamotrigine. And although I know you guys may have already glanced over chapter 12 or have had a review in pharmacology, make sure that you're reviewing these medications, the mood stabilizers, but also the antipsychotics. Other interventions or things that we need to be thinking about, because we're going to touch on a few of these medications. So with lithium, you need to know why that medication is prescribed. You need to understand what the therapeutic and toxic levels are, and know that when it comes to drawing levels for lithium, anything 1.5 milliequivalents per liter and above is considered to be toxic blood level. How are we going to help them maintain their medication in the appropriate therapeutic lab value? And then what are the contraindications with that medication? Anticonvulsant drugs include your Depakote, your Tegretol, and your Lamictal. Anti-anxiety drugs that we're going to prescribe to them include Klonopin, Ativan, other atypical antipsychotics, olanzapine or Zyprexa, and Risperidone or Risperdal. Other treatments beyond medication include ECT, and WVU does it a lot. As nurses, we're also going to be heavily involved in teamwork and safety with these patients, creating support groups for them, and then engaging in health teaching and promotion. Other nursing interventions outside of administering and monitoring medication And the side effects of the medication along with the interactions, we're going to be promoting adherence to their medication. We're going to give them teaching points. We're going to provide that education on those other things like ECT, and then use some psychosocial intervention. Nursing assessment from a psychological domain. Is it their mood? Is it their cognitive function? How is their thoughts being disturbed? Do they have flight of ideas, clang association, grandiosity, issues with stress and coping? What are their risk assessments? Other diagnoses include defensive coping, ineffective coping, non-adherence that's usually to treatment therapy, risk for suicide and violence, and that is on either of those spectrums, whether they're manic or whether or not they're in the major depressive disorder. So from a psychological standpoint, when we're thinking about nursing interventions that we're going to do, this is where cognitive behavioral therapy comes in. So we're going to use psychoeducation, giving them that individual therapy, interpersonal therapy, adjunctive therapies, and psychotherapy. Other assessments include looking at the role that their cultural background plays in their mental illness. How do they deal socially or occupational? How are they able to maintain those jobs? And then looking at any changes that can result from them being manic or depressive. Nursing diagnosis related to the social domain include ineffective role performance, interrupted family processes, impaired social interaction, impaired parenting, and compromised family coping. When we're looking at our nursing interventions from a social standpoint, one, ultimately, because of their inability to really have that support, that relationship, that close connection with individuals, they're also at higher risk for self-harm and harm to other patients. They really need support groups. And then again, we need to be not only treating the patient, but also treating the family, looking at parenting skills, counseling sessions, using intensive family therapy, and then some family psychoeducation as well. What are our outcomes? Well, during the acute phase, which is usually on the onset of either them coming to the ED or coming to the unit, is to prevent injury. Then in the continuation phase, we're trying to prevent the patient from having any relapse. And in the maintenance phase, we want to limit the severity and the duration of any future episodes that they have. So how do we plan this? Well, in the acute phase, one, we're going to be using medications to stabilize them. We're going to be maintaining a safe environment for them, and then we're going to be assisting them with their self-care needs. Now, in the continuation phase, we're preventing relapse, so we have to help them understand the importance of adhering to continuing to take their medication, to continue going to their psychoeducational therapies, and then to use the referrals that we're providing them. And then from that maintenance phase is really just preventing that relapse. So now we take these things that we're planning to do and now we have to implement them. So from the acute phase, we're looking at implementing interventions based on whether they're in a depressive mood or manic mood. We're in the continuation phase, that's about preventing relapse by making sure that we have follow-up care provided for them because they need that support, they need that therapy, they need to continue with their psychoeducation. And then in the maintenance phase, we're preventing reoccurrence. Using the maintenance phase, that is really the big deal is we get them and we're treating them, and now we're done treating them and we're giving them the information they need to prevent relapse. And in the maintenance phase, if they're in that phase, and that means they were able to take everything that they took from the continuation phase, put it into practice, and now we've put time in between the next time that they come and see us because they're being compliant. Now we've implemented all these things. What do we do to evaluate? In evaluating our outcome, our goal is to return the patient to a pre-crisis functioning. So how do we evaluate the goal? One way is having a patient who tells us after they've been admitted and they receive the help, that the patient will have returned back to life and work and are doing well. So you can see that they're in that continuation phase and they got that maintenance phase going very well. Evaluation also requires that we reassess their care plan and then revise the care plan based on their needs. So maybe they're doing okay with the medication, but they're missing here and there. Then maybe they need to be re-educated and needing a little bit more support from outside or from family. When we think of the continuum of care, we're taking care of them in the inpatient, but there are also some intensive outpatient programs through partial hospitalization or day hospitalization. If you do not know what these are, I refer you back to set the settings. If I'm not mistaken, it's therapeutic settings. Go back to that chapter and look that over. And then we have to make sure that they have some extended therapy and continued follow-up. There are some practices that nurse practitioners usually engage in, and these interventions include psychotherapy. That is usually done by your advanced nurse practitioner or a psychiatrist. But for instance, since we're talking about nursing, know that only nurse practitioners do psychotherapy, and that includes your cognitive behavioral therapy and your interpersonal and social therapies. How do we promote mental health? Well, during the remission period, we want to make sure that we're teaching them how to deal with stress and how to cope, give them relaxation techniques, and develop a plan for what they need to do when symptoms emerge that says they might be having going in either direction of an episode. So now let's look at some questions. The first question asks, which agent would most commonly be prescribed for a patient with bipolar 1 disorder? Is it A, lamotrigine, B, lithium, C, carbamazepine, or D, divaproex? That's your Depakote. See, I'm narrowing it down. I'm going to say, what is it asking me? Which agent will most commonly be prescribed for a patient with bipolar 1 disorder? So does that mean we're looking at all of them, but one is used more often? I would go with lithium, but let's see. All right. And it is lithium. Although Depakote, carbamazepine, lamotrigine may be used as a mood stabilizer, lithium is the most widely used mood stabilizer. So there we go. Is the following statement true or false? An expansive mode is characterized by euphoria. And that answer is false. An elevated mood is characterized by euphoria. An expansive mood is one involving a lack of restraint in expressions and overvalued self-importance. Now we have a case study. So we have a patient that was just admitted to your unit with bipolar disorder 1 and is in the manic state. What symptoms might you see? Well, we've talked about this before. Manic, they might have extreme drive, they might have a lot of energy, an inflated sense of self. They're not sleeping because we talked about some of their diagnosis, sleep deprivation, right? Excessive talking with pressured speech, racing thoughts. They can be distracted. We talked about their impulsivity. So they're making quick decisions that puts them, they're not thinking about it. Their decisions when they're making them, that's why they're risk to themselves. Their distraction, they're distracted by what's going on around them. They can be unusually obsessed, over focus on goals. They may have issues with dangerous activities, lack the ability discriminate spending, can be reckless when it comes to sexual encounters or risky investments. Alrighty, let's go into the next case study question. So a patient, well, I thought it went down. Let's try that again. All right. So your patient with mania has been started on lithium. What patient teaching about this medication should the nurse provide before the patient is discharged? Now, I'm not even looking at my notes yet, but I'm going in my mind. We talked about lithium. We talked about toxicity. So maybe that might be on my list of things that they're going to have regular lab draws to make sure that their medication is therapeutic. So let's see. Well, we're also going to have to educate the family as well, as to why they're on a medication. With all medications, we talk about adverse effects. There it is, toxic effects and complications. Um, Looking at moments and when they're going to have to contact the physician. They're going to have frequent blood tests. And that the two major long-term risks of lithium are hypothyroidism and impaired kidneys. So their ability, because so now we're going to have to be making sure that we're assessing thyroid and also how are their kidneys functioning. So next question, which anticonvulsant medication might be prescribed for a patient with bipolar disorder? Is it Depakote? Is it Klonopin? Is it Zyprexa? Or is it lithium? Now I know we talked about lithium already because lithium is a mood stabilizer. We talked about Zyprexa and Klonopin, but we talked about giving those medications if they have anxiety. So let's see. Am I looking at Depakote? Well, let's find out. I ruled them out, and I'm down to Depakote. And that answer was A. It is Depakote. The next question is the following statement true or false? Protecting the patient from self-harm is crucial during a manic phase. And that answer is true. During mania, patients usually violate others' boundaries. They may miss the cues indicating anger and aggression from others. Thus, protecting the patient from self-harm as well as harm from others is going to be important. So, what are things that can trigger mania? Well, this is definitely going to be an important question for you guys. So let's look over into the next slide to see what that is. It can be treatment with steroids, because we know that there can be some being enraged. Guys, I can give you stories about my own experiments taking steroids. It keeps you up all hours of the night. If you're not used to it, some people, that's how it's affecting them. With mania, if they're already up all night, then we're not helping the situation. Amphetamines, TCA, hyperserotonin, infection. Why is that? Most people forget that if they have infection, there's a lot going on in their body, that their body is already dealing with the fact that the body is going at a 24-hour mile. It's constantly going. That individual isn't sleeping. They're already having racing thoughts, and now they have an infection. There's a lot going on, and so those individuals will respond. Hypothyroidism, sleep disturbance, neoplasms, those are all things that can trigger mania. So let's ask a question, bringing us to the very end. A client who is displaying symptoms of mania approaches a cognitively impaired client and orders him to do push-ups or be pushed down. In order to best provide for a safe milieu, the nurse should immediately implement which intervention? So now let's look over the question. What should you guys be thinking about? Because one of the things that my students always ask is, how do I determine what I need to pay attention to in these questions? So what information is important? Well, I have a patient that has mania. Immediately I'm thinking safety, harm themselves or harm to others. because they're just not aware of environmental cues from other individuals. Now, the client approaches someone who is impaired and orders him, and let me show a client who is displaying symptoms of mania, approaches an impaired client and orders him to do push-ups or push-ups. Well, that's not going to go well if you have a cognitively impaired client and you have a patient that's mania being very aggressive with their behavior. But again, you got somebody that's cognitively impaired. You got two different groups of people who just may have the lack of insight or judgment and can be impulsive. So, how do we provide the best milieu? What can we implement immediately? Well, we can remove the cognitively impaired client from the milieu. Not really sure about that. Inform the entire milieu that verbal and physical threatening is forbidden, possible. Escort the manic client back to his room where staff will keep him under observation. Okay. And D, distract the manic client by asking him to show the staff how to do push-ups. Well, right now, if you're telling me you're going to do push-ups or be pushed down, I think that you're a harm to someone else, and I don't think that you can be distracted at this point, so I'm going to rule that one out. The cognitively impaired person, they were minding their business, and they're not making any threats, so I'm going to rule that one out, and so now I'm down to B and C. And in B, I'm given the option to inform the entire milieu that verbal and physical threatening is forbidden. Well, I don't think the person in mania is going to be able to really hear that and understand that, especially the cognitively impaired client. So I'm going to assume that it's C. Escort the manic client back to his room where staff will keep him under observation. Why is this my best choice? It's an intervention. I'm getting ready to do something. I am physically taking the manic patient and walking with him back to his room, and then I'm going to sit with him and observe him. And why am I observing him? Because if this individual is making statements to harm another patient, then they have to be one-to-one. And because they're in mania, they're at an increased risk of harm to themselves. So this not only balances the milieu by keeping it safe, it takes the patient back to their room and keeps them safe. But while I'm observing them, I can then engage in conversations that might distract the patient. So the answer is C. And with that, we've come to the conclusion of our lecture today.